Today we'll be talking about lower respiratory conditions. So we're going to go over asthma, then COPD, acute bronchitis, and then pneumonia. So our first two are really looking at obstructive disorders, while the second two are looking at infectious processes. So starting with asthma, so asthma is a chronic inflammatory disease of the airways. In the U.S., it affects about 26 million, or 1 in 13 people. If over 5,000 people die from asthma annually in the U.S., and then it has an increasing prevalence of mortality that are greatest among inner-city residents, racial minorities, people with a lower socioeconomic status, and then women and children are more greatly affected. Highest rates are actually in Puerto Ricans, but then African Americans have the highest prevalence, hospitalization, and deaths related to asthma in the U.S. So as a pathophysiology review, this is really about inflammation and airway obstruction. So there's airway edema, bronchoconstriction, mucus plugging, so an excessive amount of mucus is made, and then airway wall remodeling. And that remodeling happens over time. It's more vulnerable, making people more vulnerable to lung issues later in life. In general, though, when we're comparing asthma with COPD, we think of asthma as being reversible airway obstruction, whereas COPD, it's chronic and progressive. So looking more specifically at adult onset asthma, it can occur in a variety of situations. Allergens typically are playing a pretty big role, though sometimes we don't see a family history or IgE antibodies. We usually will. Occupational exposure to workplace materials is a big piece of this, and whether that causes it or whether it's an exacerbation component, it's worth asking history questions related to this, more specifically because it's in the context of an adult onset asthma situation. So is there some kind of a new allergen? Okay, so clinical presentation, recurrent episodes of cough and wheezing, chest tightness, shortness of breath. Symptoms can be associated with activity or allergens. They may present with just a cough and no wheeze, so I think that's something just to be aware of when you're asking questions. And oftentimes with that cough, there's a thick, clear mucus production component that comes too. So consider that even if somebody's not having wheezing but is having a chronic cough. So in assessing their medical history, you're certainly asking about the symptoms we've already talked about. Definitely, it's common to see a family history of asthma or allergies. So you're looking at kind of that constitution. You're assessing for the severity of their asthma, if they do have it, and identifying possible precipitating factors or allergen components. So for their physical exam, you want to assess their upper respiratory tract, thinking about rhinitis, nasal polyps. You'll do a chest exam. So are there retractions, barrel chesting? That would be more common with COPD. And then their skin, rashes, eczema, atopic dermatitis. It's not uncommon for those to also accompany somebody who has asthma. So pulmonary function testing is typically done by pulmonologists, so it's not as common in the primary care setting. So if you suspect somebody has asthma, you'd send them out, and then once they're formally diagnosed and set up with a management plan, you could certainly take over their ongoing management from there. But still important to be aware of what's being assessed. So basically you're looking at the forced expiratory volume in 1 second, that's the FEV1, and then the FVC is forced vital capacity. And when you look at these measurements, it's really important that we're comparing them to patients with similar age, height, sex, and race, especially for the elderly, because they're a lot more commonly misdiagnosed because they're not being compared to the right age group. So you're doing this assessment, and then you need to make sure you're comparing it to the right demographics. And generally, spirometry, it's recommended at initial assessment, after treatments stabilize symptoms, and then about every 1 to 2 years. Peak expiratory flow meters are another way that we're measuring large airway function. And basically, you want to measure this compared to a patient's personal best. So that's how we know that the management plan they're currently on is effective, is comparing it to their own personal best. So we're checking in on how they're doing based on their own personal best to determine if treatment's effective. So there's a lot of host factors that can influence the severity for asthma. So if somebody has rhinitis or sinusitis, for example, that would exacerbate their current asthma. Same goes for any other kind of viral upper respiratory infections, GERD, sensitivity to certain drugs. So I've listed a few there. So just being aware of what can cause exacerbations. And then your differentials. Underdiagnosis is frequent. So definitely recurrent episodes of cough and wheezing are almost always going to be due to asthma. But you want to consider COPD, heart failure, mechanical obstruction of the airway, such as a tumor or foreign body, cough, like if they've just started an ACE inhibitor, and then vocal cord dysfunction would be another possibility. So therapy goals. So obviously we're wanting to prevent chronic and troublesome symptoms relating to having difficulty breathing. We want to be able to maintain normal peak flow, maintain normal activity, and then preventing recurrent exacerbations of asthma and minimize the needs for ED visits or hospitalization. So pharmacological management, basically this is about having some form of a prevention medication and then a rescue medication if they're needing it. And ideally, if we've got a good prevention medication on board, they're not going to need their rescue med very often. So you'll get into more detail on this in pharmacology. But basically for long-term control, you've got your corticosteroids like Flovent, long-acting beta-2 agonists. So you've got a few different options there. And then quick relief, short-acting beta-2 agonists, most common is going to be albuterol. Anticholinergics, which we're also going to use with COPD, and then systemic corticosteroids. So I know this looks like a pretty busy slide, but it really is a goldmine. I think this page would be worth you printing out as one full page rather than just printing 6 to a slide or what have you. So basically this is saying how are we classifying asthma? So initially, we're going to look at it as classifying it into either being intermittent or persistent. And then if it's persistent, there's mild, moderate, and severe. And then you can see here, we've got our spirometry findings for loosely what we'd expect based on age. And then basically, we're looking at our symptoms. So if they're experiencing, let's just look at intermittent for a minute. So if they're experiencing symptoms less than 2 days a week, nighttime awakenings are less than 2 times a month, and they're not needing their rescue medication like albuterol, that'll be less than 2 days a week. It's not impacting the normal activities of daily living. And then this gives you general parameters for their spirometry findings. Then that would be intermittent. And then you can see here this would link you to what you would do for treatment. But just for initial classification of knowing where they're falling, that's how you'd classify it. And then now we've got slides kind of looking at each one a little bit more closely. So starting with intermittent then. So mild intermittent asthma, again, that's our parameters. And in this case, we really don't need a controller medication. Just having a rescue medication is fine for quick relief. So having like albuterol, for example, or you could use cromolyn if they aren't tolerating albuterol very well. That would also be an option. And they could do that before exercise or any other kind of triggering times in their life. Thinking about cold temps or allergen exposure, that they've got that rescue med if they need it. But again, it's less than 2 times a week and less than 2 times a month that they're being woken up at night with symptoms. Okay, so then mild persistent asthma. This is when they are having symptoms 2 or more times a week, but it's not daily. So that's kind of your threshold for thinking mild versus intermittent. And this is the point where we do want to add a controller medication. So they still have their albuterol to do as needed, but if they're needing to use it more than twice a week, that's too much, and we really need to get a controller medication on board. So you can add like an inhaled corticosteroid, leukotriene modifier, so that's kind of what your approach would be there. And then for moderate persistent asthma, basically symptoms are daily, and then we'll want to do controller meds along with probably a leukotriene modifier as well as the albuterol. So you can, your adding in Singular in addition to like an inhaled corticosteroid and long-acting bronchodilator. Okay, so then severe persistent asthma, continuous symptoms. So they're going to be on multiple daily controller medications, and definitely at this point, and probably at moderate, honestly, too, you're going to want to pull in their pulmonologist or other person they're working with if you're realizing their current plan is, if there's severe persistent asthma. If they're not on enough of these medications, then you could consider adding it while they're waiting. Like if it might take 2-3 months for them to get in with their primary pulmonologist, then this would be something that you could do to help cover them until they can get in to help with stabilizing it. But I would want to pull in somebody else at this point. So for either co-managing or sending them back. But you being able to recognize what category they're in as their primary care provider is a part of the safety plan there. Okay, so asthma patient education. So what are our goals here? So adherence to the regimen, importance of controller meds. Sometimes people are expecting kind of fast-acting relief from their controller meds, and if they're not getting that, they don't see them as useful and just want to use albuterol. So making sure they're understanding the importance of their controller meds and aren't just relying on their rescue medications. Assessing their inhaler technique. You might want to consider using a spacer like this picture shows here if they're having a hard time coordinating well with inhaling at the right time in order to get the best benefit from their medication. Counseling on side effects of medication. So beta agonists specifically can cause nervousness, tachycardia, which is why cromolyn can be a nice substitute if the beta agonist isn't being tolerated well. And then talking about symptoms and activity and making sure they recognize that our goal really is that they can do their usual activities of daily living and whatever kinds of activities they used to do that they haven't been doing, we want to get them back to that place again. So that's really our goal. So at what point would we be referring? So definitely if a patient's had a life-threatening exacerbation, if they're requiring continuous oral corticosteroid therapy, if they've been unresponsive to therapy, or if you think additional testing might be necessary. I think specifically for if we're suspecting an underlying allergy component, that would be worth a referral for a thorough workup there. Uncontrolled GERD, same thing. That can really be an exacerbation piece. Also asking them how often they're using their rescue inhaler. That's really a good place to start for just knowing where they're at. Okay, so switching gears to COPD. So the number of people with COPD continues to increase, particularly with women. And while the death rate for men has been progressively going down over the last decade or so, it's stayed unchanged for women. It's the fourth leading cause of death in the U.S. And then it's the only major health problem in which mortality has been increasing. So we have about over 50% of people will die within 10 years of diagnosis. And then given you're all over the U.S., I included this map so you could get a sense of specifically what the prevalence looks like in the area where you're hoping to care for women. So it's the percent of the population here. So you can see yellow is about 3.5 to 4.5%, and then the dark red is about 7.5 to 12.5%. And if you want more information on your city or county or state, CDC is a great resource for you to explore that further. So COPD, it's almost always preventable and treatable. Typically it's characterized by airway or airflow limitation that isn't reversible. So it's typically progressive and inflammatory in nature, primarily from smoking or nicotine, which is where the prevention piece comes in too. So it has a lot of elements of both emphysema and chronic bronchitis. So we're going to talk about both of those two now. But it's typically not purely one or the other, so much as kind of going back and forth between the two, and it's not uncommon for somebody to present more like chronic bronchitis than emphysema or vice versa. And sometimes chronic asthma can play a role as well. So emphysema gets nicknamed our pink puffers compared with our blue bloaters of chronic bronchitis. So pink puffers, they tend to look skinnier, muscle wasting, prominent thoracic cage due to hyperinflation. So that's kind of what you're picturing. And then basically it's abnormal permanent enlargement of the air spaces distal to the terminal bronchioles, and then that's accompanied by destruction of the walls. And then it has a fair bit of neutrophil enzyme action there, and then results in progressive hyperinflation of the lungs. So basically it's really hard to get air out of the lungs. So the pink part, the air is in the lungs, so we are perfusing, but it's hard for us to get air out of the lungs. I think that's good for emphysema. So then chronic bronchitis, or our blue bloaters, we have a narrowing and obstruction of the airway. Basically, it's harder for us to get air in. So in emphysema, it's hard to get air out. Chronic bronchitis, it's hard to get air in, and you can see why blue or poor perfusion would be a component of that. So typically has more of an inflammatory response there, as well as excessive mucus production. That mucus production will typically present more as a chronic productive cough, whereas in emphysema it's typically more of a dry cough. And then chronic bronchitis, you're also more likely to see an expiratory wheeze. So the formal definition for chronic bronchitis would be somebody who's presenting with a chronic or recurrent productive cough, and then to formally diagnose it, it would need to be present on most days for a minimum of 3 months out of the year for 2 years in a row. So that's your formal definition. And against COPD, you might see some of both of these. So it's not as important that we be able to differentiate the two perfectly, but having a sense of kind of the gestalt of what each would present as. Okay, so then there's your chronic bronchitis blue bloater versus your emphysema pink puffer, and how you might see those presenting differently. So back to COPD then. Risk factors. Smoking is definitely the number one risk factor at 95% of people with COPD. Gender, it is more common in males, and then definitely with age, that increases risk as well. The onset's typically in people's 30s if they're smokers and 40s if they're non-smokers. Consider air pollution and occupational factors. That's basically where that other 5% come in terms of what sort of allergen they might be regularly exposed to that's toxic, that's not nicotine. And then for cigarette smoking, we see that as being the primary risk because it's releasing oxidants and free radicals, increasing neutrophil population in the lungs, and then suppressing elastase inhibitory activity as well. So everybody's FEV1 is going to start to go down a bit around age 35, but that rate is quite a bit faster and steeper for smokers. And then I think it's worth noting that if people quit, though, quite a bit is reversible. So right away, right off the bat, when people quit, a small amount of lung function is immediately regained. And then they're going to continue to regain more and more lung function and an improved FEV1 with time, where given enough time, their rates can look almost identical to those who've never smoked. So in terms of motivating people to quit smoking, that's a huge part of COPD treatment for those that are open and willing. So again, clinical features, typically smokers with a mean of 20 cigarettes a day for 20 years. So 20 cigarettes is about a pack. So that'd be a pack a day for 20 years, about a 20-year pack history. Usually presents in the 5th decade of life with a productive cough or acute chest illness. And then dyspnea on effort begins usually 6th or 7th decade. And again, remembering that it's about half of people, a little over half of people, once they are diagnosed, they die within 10 years. So this is serious. Comorbidities, not uncommon to see weight loss, nutritional abnormalities, skeletal muscle dysfunction, and then comorbidities, you can see that whole list there, but MIs, osteoporosis, respiratory infections. So not uncommon to see more than one thing on the problem list. So let's just do a brief comparison of COPD versus asthma. So asthma, typically it's an early onset in life, often it's childhood, versus COPD is midlife, 30s or 40s. Symptoms can vary from day to day. For asthma, where COPD it is getting progressively worse. Symptoms at night and early mornings are common for asthma as being kind of trigger times. And then asthma definitely has an allergen component, rhinitis, eczema, kind of that constellation that we're not seeing so much with COPD, and more so that long smoking history being key. Asthma oftentimes has a family history. That's not the case for COPD. And then largely reversible airway limitation versus it being irreversible for COPD. And then dyspnea during exercise, honestly, we could probably see that with either. Okay. So history taking for COPD, asking about smoking, environmental exposures. So emphysema, we're thinking about dyspnea and a dry cough, versus chronic bronchitis, we're thinking about a cough that's more productive with white or gray sputum, worse in the mornings, also dyspnea. So we're asking those kinds of questions to describe your cough. Are you ever noticing blood? Those sorts of questions. So early findings, you might see tobacco-stained fingers, so like yellow fingernails, lung sounds, wheezing, coarse rales, rhonchi, prolonged expiratory phase respirations, distant breath sounds. You might see some barrel chesting too. Late findings, tripod positioning they've pictured here, using their accessory muscles to be able to breathe, pursed lip breathing, cyanosis, heart failure, especially right-sided, would also be possibilities. Okay, so diagnostic tests. So you're probably not seeing somebody and doing this for the first time. Though that said, you may have been seeing somebody for years and you're their primary care provider and they don't see anybody else, and you may be the one doing this initial workup. So from there, as results are coming back as potentially abnormal, it wouldn't be uncommon for you to then just refer them on for a full initial startup management plan with a pulmonologist, and then you could continue or maintain that plan that's been started, or at the very least, you're still seeing her for annual exams. And it's important for you to recognize what else is going on in the background for her management plan. So those initial diagnostic tests, you might do a chest x-ray to exclude other diseases. Chest x-ray could show hyperinflation, vascular pruning, blood work, CBC with DIS, for example. So management of stable COPD. So this is more like what we'll encounter. And then you want to make sure that for spirometry that, again, you know what their baseline is with a bronchodilator. So they would use their bronchodilator, and then they would have the testing done. And then it's important that we're comparing their results to people with similar age, race, gender, so that the demographic comparison is comparable there. Especially since COPD can be overdiagnosed in the elderly for that reason. So that's spirometry. And then for patient education, talking about what it is, why are they having certain symptoms. It might be air pollutants, certainly smoking if that's a factor, occupational dust, chemicals, that sort of thing. Purpose of medications they're taking, counseling on risk reduction, again, that's primarily smoking, or changing jobs, or, however that looks for their situation. Nutrition, it's not uncommon to see weight loss, and that could be due to a number of different things. That can be altered taste perceptions, if they're heavy mouth breathers. If they have a lot of air trapping in their lungs, they might be feeling full too soon. Depression can impact how much they're eating, so that's something to be assessing. And then assessing readiness for smoking cessation. So by this point, you've already had a good chance to explore motivational interviewing. But my favorite two questions are to have people give me on a scale of 1 to 10, how ready do you feel to quit today? And then if you did attempt to quit today, how successful do you think you'd be? And then you can really guide your discussion based on what their answers are. So if it's a 1 and a 1, then today's not going to be a day to spend a ton of time on it, but perhaps just to plant seeds. Definitely having an emphasis on discussing motivators. And I think, most people are going to know that smoking has health consequences. So I find that generally negative motivators aren't as good at propelling people forward as much as positive motivators are. So, maybe it's wanting to be able to go to their grandson's basketball game and not feel so exhausted from the experience and like they're huffing and puffing to get through it. So whatever it looks like for them, to really explore that, and that can be part of planting the seed. Whereas if they are presenting with a higher number readiness to quit, and feeling like they'll be successful, talking about a lot of different strategies, hypnosis, you can be prescribing Chantix or Zyban, talking about patch, gum, nasal sprays. So a lot of different options there. And you've had articles related to smoking cessation as well, so I'll default to that for you. So you can see here for the COPD therapy chart, staging is based primarily on spirometry, and then those bottom tiers there are indicating management. And maybe you really aren't the provider that's managing their COPD, but you are still their primary care provider and they're seeing you for annuals. So you should be familiar with what their management goals are and recognize why they're taking the meds they're currently on and what that's saying about their current staging. So you should be able to ask a few key questions to check in and know that their current management plan is still appropriate. So maybe they weren't planning to go back and see a pulmonologist for another 5 months, but based on what they're on and what they're telling you for their symptoms, you may recommend that they go see them sooner, for example. So treatment in general will typically involve bronchodilators, so beta-2 agonists is needed, anticholinergics, they tend to respond better. For anti-inflammatories, they might be on prednisone briefly and then weaned off of it. For rehabilitation, like exercise training programs, this can really help with improving dyspnea and fatigue as well as their exercise tolerance. So this can be a huge part of just keeping them stable. So especially if their COPD is affecting their activities of daily living, recommending and encouraging them to continue with their rehab can be a big part of their care. And then oxygen therapy, long-term administration, so 15 plus hours a day has been shown to increase survival. So it can be hard to get air out of their lungs, so that's why the goal is that it's at least 90%. And that would be appropriate rather than having a goal be higher than that. Other treatment options, antibiotics. You're typically only doing this to treat infections or some kind of exacerbation. Like if they're developing bronchitis, for example. Drug of choice would be like a macrolide, amoxicillin, a cephalosporin. Making sure that for vaccines, they're getting their flu vaccine every year and then the pneumovax every 6 years. Antioxidant agents could possibly be a part of their care. Otherwise, for people with stable COPD, we don't recommend mucolytic agents, antitussives, or vasodilators. Okay, so switching gears to acute bronchitis. It's the 5th most common illness diagnosed in primary care. There's more cases in winter and spring, and it's typically viral and typically self-limiting. So for history taking, this is often somebody who had an upper respiratory infection and is now presenting with a persistent cough following that upper respiratory infection. They typically have a productive cough, clear mucoid sputum. They may also have a low-grade fever, headache, malaise. On physical exam, they might have a mildly elevated temp, pulse, or respiratory rate, or they might have normal vitals. Breath sounds, you might notice some diffuse wheezing or fine crackles. Possibly rhinitis on exam as well. So your main differentials are going to be pneumonia, heart failure, drugs, like if they've recently started an ACE inhibitor, GERD, can also present as a chronic cough. It's generally not too tricky to differentiate it. Pneumonia, if you're at all wondering, you can order a chest x-ray, and that'll help distinguish it since that's the gold standard for diagnosing pneumonia. And then heart failure, like you'd expect edema and blood pressure issues, and so generally acute bronchitis isn't too tricky to tease out. So for non-pharmacological management, smoking cessation, and then otherwise really focusing on hydration and rest and nutrition, if that's your primary focus. For pharmacology, antibiotics are fairly controversial, and it's almost always viral. So unless it's developing into something that's bacterial or developing into pneumonia, you're generally not prescribing antibiotics. Inhaled bronchodilators can be helpful, so that's something to consider. You could do a cough suppressant, but you really want them to be able to get it out so that it doesn't develop into something worse. So having a bit of a cough and being able to work it out is good. But if it's to the point where they're not able to sleep at night, then you might do a cough suppressant, and then they could use acetaminophen for fever comfort. For education, you want to tell them to avoid antihistamines. Let them know that the cough can last for 2 to 3 weeks, to make sure they're increasing fluids, eating really well, resting well, coughing it up, getting it out, and then follow up. They can return to the clinic if symptoms worsen or aren't improving after 3 weeks. So now we're going to talk about pneumonia. Prevalence, definitely higher in the very young and very old, more cases in the winter. Most common pathogen is Streptococcus pneumoniae, but H-flu and M. catarrhalis are also not uncommon. 6th leading cause of death. Mortality is 1 to 5%, but it's over 20% in hospitalized patients. As far as the clinical presentation, they'll have a cough. It can be wet or dry, but you'll probably notice sputum production, dyspnea, fever. This is going to be higher than bronchitis because it's more likely to be bacterial. So we're thinking bronchitis, generally viral, and pneumonia, we're thinking bacterial. Tachypnea, crackles or rhonchi, increased fremitus, dullness to percussion, pleuritic pain on inhalation, and then night sweats. So for your workup, your differential list would have acute and chronic bronchitis, asthma, pulmonary embolism, CHF, just as some examples. Diagnostic tests, definitely your chest x-ray is your gold standard, looking for lobar segmental consolidation, and you want to make sure that your patient's really well hydrated, because being dehydrated can cause a false positive. So send them out the door to go to the chest x-ray with a water bottle. And then for labs, you want to do a CBC, you might notice elevated white blood count, and then ABGs would give you a sense of the severity. You can check O2 sats, and then you could do a sputum gram stain or culture. It's a little controversial, but it could be helpful in less common etiologies or to detect resistance in patients you've already treated. You might want to consider it too if they have comorbidities like COPD, but generally not needed routinely. So bronchitis versus pneumonia, just to think about how we're comparing the two. So bronchitis generally tends to be a gradual onset, so they might first have an upper respiratory infection, and then it's kind of like this lingering cough from there, versus pneumonia tends to be more of an acute onset. You might see an absent or very mild fever with bronchitis versus you will see a fever in pneumonia. Those with bronchitis may talk about having like a vague tightness or chest compression versus that intense pleuritic pain on inspiration. It would be much more common or classic for pneumonia. Usually you're not going to see dyspnea with bronchitis versus you will with pneumonia. And then vital signs might be a little bit off or normal with bronchitis versus with pneumonia. You tend to see tachycardia, tachypnea, fever, so their vitals are off, and then they look a lot more sick as opposed to bronchitis. They generally don't appear to be in any major distress. But if you're debating between the two, get your chest x-ray. So treatment, if they're less than 61 with no comorbidities, number one would be like a macrolide, but you could do a tetracycline like doxycycline, for example, if they had an allergy. If they're older than 60 and or if they have a comorbidity, they're thinking about like a second generation cephalosporin or Bactrim, possibly a fluoroquinolone, and you definitely want to think about if you should be admitting them, particularly if they're older, and at the very least keeping really close tabs on them. So risk factors, which would definitely help you consider whether or not it would be appropriate to admit them. So risk factors, age over 65, having a comorbidity like the ones there, having a respiratory rate that's over 30, diastolic blood pressure less than 90, temp that's greater than 103, change in level of consciousness, and then white blood count that's either pretty low or high. You can see the numbers there. Generally speaking, though, if you're debating, then it would be worth you consulting whether or not they might need to be admitted. So, maybe one example is a college student comes in and she is experiencing a cough. You're thinking it's bronchitis, but you order a chest x-ray just in case, and it does come back as pneumonia. She's not feeling great, but she's got dorm mates that promise they'll help her rest and drink good, stay well hydrated, eat well, and so you go ahead and prescribe her antibiotics outpatient and plan to check in with her soon, versus if you have an older woman who's presenting and looking really ill, definitely would want to consider admitting her at that point. And there are tools like the CURB 65 scale, for example, that can help you determine whether or not it would be appropriate for you to admit. So definitely utilize those tools as well. All right, that's everything I've got for you. Your textbook does a great job, too, of breaking a lot of this content down, and hope you guys have a good rest of your week.